This video is my level 2 fieldwork in acute care and inpatient for occupational therapy. I have another video on my first level 2 up on my channel, but in this video I'm going to go week by week for kind of so you can see what it's like week by week as I progress and get a feel for what it might be like if you're going to do level 2s. This is not the best setup in my car. I will explain kind of later while I'm here, or why I'm in my car, and how that has played into my fieldwork. And I'm going to be looking down because I have a note sheet written. Alright, so the first thing is I didn't really know what to expect with acute care and inpatient. I found it really confusing, the difference between the two. So I have learned that acute care is anyone who gets a room in the hospital and stays overnight. So if you're down in the ER, you aren't acute care. You haven't been admitted most of the time, unless they're like really don't have space for you upstairs. But once you come out of the ER and stay overnight in the hospital, it's considered acute care. So there are all different types of people and levels and needs, but it's all acute care. And then you have inpatient rehab, which is its own special unit, and you have to have like certain diagnoses to get into that unit. And there they get 3 hours of therapy per day, and it's a very intensive unit, and people in there have to be essentially able to get to independent to go home within 2 weeks. So to start things off, I am currently at week 7, sorry, of this fieldwork experience. Last time I filmed each week, but my very first week of this fieldwork, I had an apartment fire. So I'm not currently in my apartment. I have been at a hotel for 6 weeks now because our apartment is uninhabitable. Luckily, our apartment insurance is paying for it. Make sure you have apartment insurance if you're renting. But it just added a whole nother layer to this. So the best place I have to film this is my car. And also because of everything happening, I didn't really have time to sit down and film. So we're getting a midway check-in. So in week 1, I had been going back through my old PowerPoints trying to save them because they're all on Canvas. I never like wrote all my PowerPoints or anything like that. I just took my own notes. But I realized that I, spent a lot on this education and should save them somewhere before I lose access. And it was really interesting to see that there's just so much that I was taught about that now that I'm in fieldwork, I could use and was like, oh my God, this would have been really helpful. But at the time, it just meant nothing to me because I had no basis to understand. So definitely go back through your stuff before you start fieldwork if you have like certain settings or diagnoses notes. My fieldwork educator wasn't there on the first day, which made me really nervous about what type of fieldwork educator she was going to be, but she's really nice. It's just kind of a situation of OTs are expected to take students, but they're not given any leeway in that. Like, they still have the same productivity standards, so it's hard to manage. Like, she had to work that weekend, and so she could come in on my start date and miss her day off and not have another one, or she could put me with a different OT and just meet me the next day. So that's what she did. So versus the nursing home where I was doing 2 to 3 evals a day and then the rest were treatments, I quickly learned that everything was evals. Now, because we have a lower census, I'm doing a few treats, but everything we were doing in those first few weeks were evals, whether they were inpatient or acute care. Something I wrote down is normalize that it's going to be really boring at first because you're not doing anything, and sitting and watching somebody document, even if you're trying your hardest to pay attention, can get really repetitive after a while. I also realized that my fieldwork educator, in my last site gave me a clipboard that I could use every day, and I gave back to her at the end, and I quickly realized that I needed to get a clipboard because it's super helpful in fieldwork, so that's something you should bring if you're going into fieldwork. And I tape like the guides I need to it. I'll do another video about that. I felt a lot less anxious than I did with my first fieldwork because, especially going into adult settings, to medical adult settings, I already knew what to do for the most part. So there was a lot less confusion, but there was still some anxiety at the feeling of how am I gonna get up to doing all of these things. It lasted a lot less in this one, because once you learn the like intricacies of your second field work, if it's in a similar setting, you were just doing it all by yourself, and so there's less anxiety. But I can imagine if you're going from like adults to peds, then you're starting over all over again. And I used the same schedule as last time, so essentially the number of weeks is how many patients a day are mine. So the first week on that list is just to do one eval. I did 4, but like spread across the days. And it wasn't like completely all me. She was quite involved. And then as the weeks go on, you step it up. So the next week it's 2 a day, so on. I also found it really interesting that productivity is not in minutes. It's in units, which units are minutes but packaged differently. So units are specifically blocks of patient care time. So in acute care, they wanted them to get around 10 units a day, which is about 8 to 10 minutes. So that's about 80 to 100 minutes a day, which is way less than in the nursing home, which makes sense because the patients are a lot sicker. And so a lot of what you see in acute care are holds. And holds are just someone, for whatever reason, testing medical stability can't be seen. So then for my week 2 notes, I have that I felt much farther along than in my last field work, and I was feeling good. So that quick turnaround and recovery. I felt like for me, having a printout of the evals so that I could write down on one sheet of paper, like all of the, essentially they're, for evals, there's just a bunch of boxes to fill out. And so instead of just hoping that you're asking all of the questions you need to when you go in, looking at what's on the documentation and writing down a checklist made my life so much easier, because then I knew what to ask when I would go in, and I had everything for sure when I went to type stuff up. So I did that, and it made my life a whole lot easier the second week. Then in week 3, I started doing 3 evals a day when there were enough to do. So normally we pick up about 6 to 8, but a lot of them, especially in acute care, end up being holds. So I could do the inpatient one. We normally have about 1 or 2 in the morning. but then the rest of them I wouldn't end up doing mine because it would end up being a hold, you know. In week 4, I have that so far I've seen a lot of hypotension being an issue, especially orthostatic hypotension. So it's really important to know your vitals and understand them. And even though I feel like I have a decent grasp on vitals, I've been taking them for a while as a nursing assistant. Something that was really hard for me is that you have like some hard cutoffs where you're told like this is emergent, but most of it is very wishy-washy. Like you have 90/60 is bad for blood pressure. That's considered low, but when you're doing therapy in acute care and you know these people are sick, most therapists are very, depending on how the patient is looking symptomatically, they'll keep going, or depending on the position, etc., they'll decide that it's probably fine. And that's really hard as a student when no one can give you straight numbers, to know when to stop, when to keep going, because you want to be as safe as you can, especially when you're new. So for example, I had an experience where we were giving someone a shower and we took their blood pressure because they were becoming really symptomatic. So they were sweating, breathing heavily, etc. And it was 60/40, which is really bad. And so we immediately took it again, and I lifted their feet up and had them pump their legs, because hopefully it's wrong, but you need to act quickly if it's not wrong. And then it was 90/60, so it was coming up, but that's still like not a comfortable zone to be in a shower. And so I went and got the nurse, and my CI stayed with the patient, and I walked into the break room where all the nurses were and asked for somebody to come with me. And instead of just coming with me, they asked me a bunch of questions about like, okay, so what were the numbers, and was the water warm, and etc. And then decided that they felt fine about it and they weren't going to come and check on her, which made my CI very mad, because she sent me, and she sent me for a reason. Because from a nursing standpoint, it doesn't sound very concerning to them, and that's fine. But from a therapy standpoint, we have someone in a shower in a slippery place, it's still warm, and we have a lot of movement to do to get them back to the bed. And so to cover yourself, I would like nursing to look at them, and I want extra hands, because this person's obviously not feeling great, to help me get them back to bed. So yeah, it can be really frustrating when there's no agreed upon line in the sand. It's just kind of to each their own, and depends on who you talk to. And then another thing in week 4 I started to realize is that a big thing in acute care is, and an inpatient, but less so, is your ability to do a chart review, and to do so really thoroughly. And you can get in a lot of sticky situations if you didn't check every document in their chart. And so I had to like watch my fieldwork educator go through charts and like make a list of all of the areas I needed to check, because our documentation system is not the easiest to navigate, and I kept having instances where I would miss something and she would catch it, but like I need that not to happen going forward, because she's going to give me more and more trust. But I had a almost opposite situation where I found in someone's chart that the last doctor's order we had for their weight bearing with a fracture was non-weight bearing. And so I alerted my CI, who alerted the team, and and we did the eval and everything. And then another provider said, well, they had an imaging and it looks fine, it's clear, and so it's fine to put weight on. Very much in a way that made me feel bad. Sorry, there's an animal in one of the hotel windows. As if I was silly for bringing it up, and I should have been looking at this imaging scan and just knowing that it was fine. But upon further recollection, as an OT, I'm not allowed to just interpret imaging. I need a doctor's orders because I don't have the scope of practice to be sure that this imaging and its interpretation are correct and that we can have a different weight-bearing status. And so yeah, it can be hard to hold your ground in what you know is right. The same thing with like getting a patient up to a chair. Often you'll end up with nursing staff complaining that you left them up in a chair because they think that you're being lazy, when in reality it's just that we have to bill our services in the amount of time, and they have to all be skilled services. And so I can't just move someone back to a chair, just move someone to a chair and then immediately move them back. That's not really a skilled service. So. In week 5, I started talking in conferences. So we go through all of the patients in inpatient rehab, and we talk about like how they're doing, how they're progressing from each of the disciplines in therapy and medicine. And in that week, I really started to feel even more like I want to invest in being an evidence-based clinician, you know, doing my CEUs, knowing my terminology and my testing, because especially in, at least for me, the acute care setting is where a lot of more skilled clinicians end up. And so listening to the speech therapist and the physical therapist, they have very knowledgeable insights into a patient's function and different treatments that they're going to be doing, and how someone's progressing. And so I want to be able to be on par and also giving patients the best services that I can. And that's something I've run into as an OT student, is that in school you learn about all of the background of conditions, the theory of why and how we do things, but the actual clinical problem solving to treat a patient isn't something you're taught, it's something you learn in the experience of it. And so that's what fieldwork's for. But for example, I had someone who had bilateral hand weakness to varying degrees for other reasons I don't want to specify too much. And so we were working on brushing our teeth, and I was trying different compensatory strategies to, like, I don't want to be too specific, but open this tube of toothpaste. And none of them worked, and so I provided like some assistance so that she could open it. But I was in the moment feeling so bad that I didn't automatically know what she should do to be able to have independence. And then as soon as I left the room, I remembered what one of my teachers said, which was, don't be afraid to use the mouth. Especially with spinal cord injuries, which is what she was talking about, if you lose function of your hands and you only have that tenodesis grip, it's not very strong, and so you're gonna need to be able to, like with a toothpaste, pop it in your mouth, hold the top with your mouth, and then spin it with your wrists in order to open it. And so then I was thinking about the lady, and I was like, oh, I should have done that. But that type of connection and thinking on your feet is only something you can get through practice. And so that's what I'm doing field work for, but it does make you feel bad. In week 6, I worked the weekend with my fieldwork supervisor, and you get a day off before and after to make up for the weekend. But it was really nice for me because that meant I got to go to the ICU and then the cardiac ICU, and I really liked that. There's just something so meaningful about helping somebody who's that sick do something like sit up and, you know, maybe brush their teeth if they feel up to it. And that definitely made me feel like, you know, if I have a chance, I'd like to work in acute care. It's not like my number one, but it's definitely up there now. I think it would be really nice. I also started doing some research for jobs. I could technically apply to jobs now. I don't have my license, but it's, I guess, common, not unheard of, for people to apply before they get their license to secure a job, and then that way they're ready once they get their license. Unfortunately, in my area, there's not very diverse OT options. Like, there's OT jobs, that's not the problem. They're just mainly for nursing homes and home health, which aren't really two areas that I'm enthused about. I'd rather work in a hospital, or like more specialty services. But, you know, a job's a job when you're first starting out, and from everything you can learn something. But something I am really thinking about is just how much field work affects your career trajectory, depending on your level of anxiety, I guess. So I didn't do a school placement, and so when I see a school job pop up, I am like, yeah, I could do that. And then I think about that it's going to be a lot harder because I'm going to have to learn the ins and outs of school therapy without someone to guide me. And so I'm going to have to do a lot of research and probably continuing education before I start a position like that. Whereas if you did a school-based field work, it'd be way less stressful. You'd probably be able to go right in and be fine. And like with me, I did a nursing home placement, and I cannot imagine if you only did mental health and, say, a school, and then now your job options are a nursing home. It's going to be such a learning curve because in those two settings, you're not doing adult weight transfers, and you're not managing medical equipment, and you're also not managing healthcare documentation as much. School has its own documentation and mental health has its own documentation, but the like min, mod, max, assist and the different scales that we often are using, like KU sit and stand balance in SNFs and in the hospital setting, you're probably not going to be using in those other two settings. So it's going to be a whole learning curve, and it's going to be that way no matter where your fieldwork placements are. There's just not really a perfect world. There's always going to be something you didn't have very much experience in. So when you're talking to your CI, it's really good for you to advocate for, like, this is what I think I want to do, or for, you know, you to advocate to get two diverse settings so that you have a good set of knowledge if you're not sure what you want to do. So like schools and nursing home or hospital are probably good places to go from, because that gives you a really broad skill set to attach to different areas of OT. Yeah. I also have taken to describing OT now in week 7 to patients. I'll walk in And I'll say like, hi, I'm Brianna, I'm with OT. Have you ever had OT before? And they say no. And then I'll say, okay, well, just to give you a little bit of clarification on what that is, in OT, we look at your independence. We want you to be independent to go home. So independent, taking care of yourself, taking care of your house, getting up, those types of things. And like that can work in schools and sensory settings too, framing it around independence, because occupations can be really hard to describe in short bursts of time. So, we want your child to be independent with playing, independent with social interactions, emotional regulation, sensory regulation. We want to give them the tools to be independent with those things so they can go out and do the things they need and want to do. So that's where I'm at right now. It's a little frustrating still having, I guess if this is week 7, when I finish this week, 5 weeks left, because I feel like I have a hang of it. I feel like I could start working there by myself. Probably because I had the same type of experience before with the nursing home, and I have so much experience as a nursing assistant. And like my fieldwork educator is always talking about how I'm so ahead, and the director of that unit has said that like if they had any OT positions, they would hire me. And that's wonderful, but it's also so frustrating because then I would like to do it. Like I know I need to keep learning, and there's still so much I don't know, but also money is very critical, especially when you've had an apartment fire. But at the same time, I know that once I start working, it will be really hard to be on my own and to be responsible for things. And so I know I shouldn't wish for the future, and you shouldn't rush to start working because then you're going to be working until you die. But it's hard to live in a world where I need to pay for things and not have a source of income. So that's it for this one. I have my next 5 weeks, and I'll be sure to update you at the end of them. Well, I'm bundled up and cold, about to let my car warm up so I can head back home. But I wanted to record a clip because I had an interesting day today. I had an interesting day, like, emotionally today, which is something that, as I talked about in my other video, is a less preparable side of fieldwork, but it wasn't bad. The first person I saw, or the first moment was that somebody started bleeding, like a scab was displaced and they were bleeding, and so I quickly held pressure on it. And I was just sitting and talking with them, and they were very depressed before, but something about joking around about the scab coming loose and, but I managed not to get blood on anything else, etc. It was really nice. They perked up, and I felt like I did something good. And then the second one, we were talking to somebody who was in a really rough situation, and they kept repeating that they appreciated us coming and seeing them, and that, they're sorry that we have to help them. And I explained that, like, no, this is part of therapy, and this is why I got into therapy, because I wanted to help people do these things. And I went on to say And if it makes you feel any better, the way things work in acute care is that after we see you for the first time, there are treating therapists who come and see you. So we could have just let one of those therapists pick your treatment slip up out of our folder, but instead we picked it up because we care about you. And she started crying. They started crying. And yeah, that just, I feel good that I know I'm a caring person and that I'm able to provide people with those little moments of care and connection throughout their hospital stay. Alright, so today is December 20th, 2024, and it is my very last day of field work. I just left the hospital and I'm now back at the hotel. I'm still in the hotel because our apartment's still being worked on. But yeah, I wanted to make a video. I still haven't really processed that it's my last day of field work, but I think this might be a neat moment for me to have, and you know, why not include it? On the drive, I was thinking about that I decided I wanted to be an occupational therapist in my junior year of high school. And, you know, I did the research on what that process is like, and I've been working on it ever since. And I'm still technically not going to be licensed, but I will have a master's in occupational therapy now. I've done it. I've done my degree. It's not official until the 30th of this month, I believe, but I have a master's in occupational therapy. I'm an occupational therapist. Yeah. And this experience, field work, has been something I've been worried about ever since I learned about it. You know, it's 6 months across 2 different placements. You're working full-time with an occupational therapist, and you're getting your own patients, your own caseload. You're responsible for knowing how to handle that and evaluate them and treat them. And, you know, I was worried about being good at it, and being able to do my job properly. But I was also just worried, like, I tend to be more introverted, you could say. And so I just had a lot of anxiety about, I'm not like some other occupational therapists who are very extroverted. And I don't know if I will be graded poorly because I don't have that personality, and maybe I can't keep up and do what I need to do. Or like maybe I'm not cut out for it. Yeah, but in both of my field works now, I've done really well. And I've been told I'm a great student. And like, especially at the hospital, I think acute care and inpatient rehab a little less so, but definitely acute care are is an area that I really thrive in. And there were just multiple patients that I connected with, and I feel like I made their stays better, and I really had a tangible impact on their life. Yeah, I feel like I make people better now. I know how to be a therapist, and I know how to work towards goals. Yeah, and that's surreal. And yeah, I know that for me and some of my classmates, when you finish your didactic portion, I felt like I didn't know how to run a treatment at all. I didn't know what to do to progress people towards their goals, because in OT, you learn some specific intervention techniques, but it's not formulaic at all. There's no like, okay, I'm working with a person with this diagnosis, here are the things I need to be working on. It's very individualized. You assess those areas that a person needs to work on in the way that they do it, and then you have to figure out how to use the items around you and the time you're given to try to reach their goal with that. And I had been told that that's something you learn setting by setting in your fieldwork placement or as you do it. And that was just really scary, and I didn't know if I was going to feel like I got it by the end of fieldwork. And I do. I really do. I think there was definitely the need for me to look for like evidence-based resources. As you'll learn in school, the field tends to lag behind in that. And also just for me to know that what I was doing was actually gonna make an impact in more trickier cases, that I needed to make sure that I checked what was the best therapeutic approach. But yeah, I did it. I'm gonna make some videos going over like my day-to-day in inpatient rehab and acute care. I already did that for what it was like in the SNF. And then like my binder, the things I would carry around with me, just help. I think definitely the day-to-day is what I would have wanted to see before I went in. But yeah, as far as this video, it's done now. I, as part of my tuition, my school covers a NBCOT, the licensure exams prep course. And so I'll do that in January, and then I'll sit for the test. If I pass, I'll be a registered occupational therapist, and then I can get licensed with the state, and then I'll be an OTR/L, which is the full dotted all your T's, or crossed all your T's, dotted all your I's credential, and then I can start working. I know that a lot of people probably feel a lot of hesitance about starting work. I don't. As I've talked about, I've like had a lot of patient care experience, and so I know that I can do it. I can interact with patients and transfer them safely. It'll still be a learning curve, but like baseline, I can do that. And then like I'll just continue to grow and learn as a therapist. And I know that there will be stress taking on the full role of an OT and being responsible fully for my patients. But I feel like my field work prepared me well. And a big thing is that, as I've talked about, it's 6 months of unpaid work. Of course, you're not doing the full work for most of it, but it's 6 months where you are going to work and not getting paid. And so for me, I really want the income. I mean, who doesn't? And so there's a lot less fear. There's just motivation. And that way I can get health insurance started and stuff like that. But yeah. I don't know if I'll make day in the life when I'm working. I think it could be really helpful, but also I think there are other videos like that, and it can be really tricky to walk that line of protecting privacy while you're doing that. But we'll see. I might actually, we'll see. But yeah, other than that, it's Christmas now, and I guess I'm gonna go have a long break. Thanks for watching.